Okay, this is chapter 47, endocrine dysfunction for NUR 203. The master gland of the endocrine system is the anterior pituitary gland, which is responsible for stimulation and inhibition of tropic hormones. However, some hormones, such as insulin, are regulated by other mechanisms, which we will talk about later. This is on page 1394 in your books. These are the principal anterior and posterior pituitary hormones and their target organs. Disorders of pituitary function may be due to organic defects or have an idiopathic cause, which means they have no idea what causes it. Problem may involve a single hormone or a combination of several hormone deficiencies. Clinical manifestations depend upon the hormone that's involved, and disorders may result in an overproduction or a hormone deficiency. Hypopituitarism is the growth hormone deficiency. If you look on page 1395, box 47.1, it will show you the clinical manifestations of panhypothyroidism. There's a deficient secretion of pituitary hormones, and this inhibits somatic growth and development of the secondary sex characteristics. This is like things that change in puberty. It depends upon the degree of dysfunction, and these are 4 of the hormones that would be involved in this change. Clinical manifestations tells you about growth, normal growth during the first year, then it's slowed on a curve after the first year, then it appears as overweight due to stunted height and delayed sexual development. Diagnostic evaluation, there'd be a family history done, of course, growth patterns and previous health status, a physical examination, psychosocial evaluations. X-rays would be done, see box 47.3, page 1395, and of course blood work for endocrine studies. So the management would be treatment directed towards correction of underlying disease process. Replacement of the growth hormone is successful in about 80% of these children. Therapy is ended when growth rates are less than 1 inch per year. Girls at about 14 years and boys at about 16 years. So nurses must educate the family and the child about medication preparation and storage, injection sites, injection techniques, and syringe disposal. Administration of growth hormone must be done on a regular schedule at a specific time of day, preferably at bedtime. Physiologic release is more normally stimulated as a result of pituitary release of the growth hormone during the first 45 to 90 minutes after the onset of sleep. Pituitary hyperfunction would result in an excess growth hormone before closure of the epiphyseal seal shaft that results in overgrowth of long bones like the humerus in the upper arm and the femur in the legs. Patients can reach heights of 8 feet or more. Vertical growth is accompanied by increased muscle, and weight is generally in proportion to the height. Pituitary hyperfunction, acromegaly. Here you can see the definition for acromegaly occurs in children. It causes giantism, where the skeleton grows very quickly as an excessive amount of growth hormone is released by the pituitary tumor. Without treatment, the child grows very tall. Typically, several facial features undergo growth, like the head, lips, tongue, jaw, nose, paranasal, and mastoid sinuses, and there may be separation and malocclusion of teeth. This is just some pictures here that explain acromegaly and giantism, and you can look at these on your own. Most of these children have a pituitary tumor and it will be removed if it's safe to do so. After surgery, it will depend on the extent of loss of pituitary hormone, whether or not they need replacement of the thyroid extract, cortisone, and possibly sex hormones. Most of these children have a pituitary tumor and it'll be removed. So, in a surgical removal of the tumor, followed by radiation and radioactive implants and hormone replacement if it's necessary. Pituitary hyperfunction, early identification of children with excessive growth rates, early treatment for improved outcomes, observation for signs of a tumor, emotional support, and addressing body image concerns. Precocious puberty is talked about on page 1397, box 47.4. It's defined as sexual development before age 9 years of age for boys and before age 8 for girls. Evaluation for pathologic cause required in white girls younger than 7 years of age and African American girls younger than 6. Disorder of the gonads, adrenal glands, or hypothalamic pituitary gonadal axis. Types of precocious puberty are listed here. You got central precocious puberty and peripheral precocious puberty. Therapeutic management for this, treatment of specific causes, if known. Lupron is used to treat in most cases. Psychological support for the child and family. Dress and activity needs to be appropriate for the child's chronologic age. Even though they may look a few years older, they should still dress age appropriate for their classmates and people that are in their own age peer group. Diabetes insipidus, the principal disorder of the posterior pituitary gland, results from hyposecretion of antidiuretic hormone. Produces uncontrolled diuresis. Primary cause is familial or idiopathic. Secondary causes, trauma, tumors, central nervous system infections, and aneurysms. Clinical manifestations of diabetes insipidus. The cardinal signs are polyuria and polydipsia. Infants will be irritable, relieved with feedings of water, but not with milk. Dehydration is often present. Diagnosed by reducing fluid intake with little or no effect on urine output. A weight loss of 3 to 5% indicates significant dehydration and requires termination of fluid restriction during testing. The child should wear an emergency bracelet and their school should be notified about the condition. Treatment is with vasopressin, which comes in many forms, and this is an advantage to the injectable in that it lasts 48 to 72 hours. However, there are dangers with the injectable. To make sure it is prepared, stored, and administered correctly is very, very important. See the nursing alert box on page 1398. Syndrome of inappropriate antidiuretic hormone, SIADH, results from oversecretion by the posterior pituitary gland, increased ADH, fluid retention and hypotonicity, kidneys unable to reabsorb water. There'll be anorexia, nausea, vomiting, irritability, personality changes, and if it's not treated, it can result in disorientation, confusion, coma, and seizures. Symptoms are alleviated with ADH is decreased. Care management, accurate measurements of eyes and nose, observation for signs of fluid overload, seizure precautions, vasopressin, and child and family education. Disorders of the thyroid function. Thyroid hormone regulates basal metabolic rate. Thyroid secretes two types of hormone, the T4 or thyroxine and the triiodothyronine, T3 and T4, and calcitonin. Patients may have hypothyroidism or hyperthyroidism, and the patients may have a disturbance in secretion of TSH. Juvenile hypothyroidism is congenital, usually congenital hypoplastic thyroid gland. It can be acquired through partial or complete thyroidectomy for cancer or thyrotoxicosis after radiation treatment for Hodgkin's lymphoma or other malignancies. Rarely occurs with dietary insufficiency in the United States. Clinical manifestations are on page 1399, box 47.5 for juvenile hypothyroidism. Therapeutic management would include oral thyroid hormone replacement, prompt treatment needed for brain growth in an infant, may administer in increasing amounts over 4 to 8 weeks to avoid symptoms of hyperthyroidism. Compliance with medication regimens is crucial. Children need to take responsibility for the medication regimen as soon as they are able. Goiter, hypertrophy of the thyroid gland, can be congenital, usually results from maternal ingestion of antithyroid drugs during pregnancy. It can be acquired, result of neoplasms, inflammatory disease, dietary deficiencies, rare in children in this country, or increased secretion of pituitary thyrotropic hormone. Care of goiter. Goiters may become noticeable during periods of rapid growth. Large ones may be obvious. Smaller nodules may be evident only on palpation. Thyroid hormone replacement is necessary, and immediate surgery may be life-saving in infants born with a goiter. Lymphocytic thyroiditis, or Hashimoto's disease, also known as autoimmune thyroiditis, most common cause of thyroid disease in children and teenagers. Accounts for a large percentage of juvenile hypothyroidism, and it occurs most frequently after age 6 and peaks during adolescence. Here are the clinical manifestations of lymphocytic thyroiditis. They will have enlarged thyroid glands, tracheal compression, and hyperthyroidism is possible. That's supposed to be diagnostic, sorry for the misspelling of that word. Thyroid function test, usually normal. TSH may be mildly elevated, and anti-thyroid antibodies are present. So therapeutic management would include surgery is contraindicated in this disorder. Goiter may be transient, asymptomatic. It may resolve spontaneously within 1 to 2 years. And oral thyroid hormone administration often decreases the goiter significantly. Graves' disease constitutes the largest percent of cases of childhood hyperthyroidism. It's believed to be caused by an autoimmune response to TSH receptors. Signs include enlarged thyroid gland and exophthalmos. I hope you all know what that is. If you don't, you need to look up a picture of that. Incidence peaks between ages 12 to 14, but the condition may be present at birth, and there is a familial association that exists. This is exophthalmos, where the eyes just appear to be bulging right out of the head. This is an excellent picture, by the way. Therapy is controversial. The goal of therapy is to retard rate of hormone secretion. So they will give them antithyroid drugs, maybe a subtotal thyroidectomy or ablation with radioiodine. thyrotoxicosis, known as a thyroid crisis or thyroid storm, may occur from sudden release of the hormone, unusual in children, but can be very life-threatening. May be precipitated by infection, surgery, or discontinuation of the antithyroid therapy, and treatment of the thyroid storm would be antithyroid drugs and propranolol. So we need to identify children with hyperthyroidism. Be alert for signs and symptoms. See page 1400, box 47.7. The child needs quiet environment, rest periods, help the family cope with emotional lability. Dietary requirements are higher to meet the needs with increased metabolic rate in these children, and know the medication's side effects. Disorders of parathyroid function regulates the homeostasis of serum calcium concentrations. So the function is to maintain serum calcium levels in the body. Increasing release of calcium and phosphate from bone demineralization. Increasing absorption of calcium and excretion of phosphate by the kidneys. Promote calcium absorption in the GI tract. Hypoparathyroidism may be caused by a specific defect in the synthesis of the PTH. May also occur secondary to other conditions like infection and autoimmune syndromes, post-operatively after a thyroidectomy, and conditions during neonatal period, maternal hyperparathyroidism, maternal diabetes, and formula with high phosphate to calcium ratios. Clinical manifestations are on page 1402, box 47.8. Same thing that's listed here on this slide. Hypothyroidism management would be, the goal is to maintain calcium and phosphate levels. Tetany should be immediately corrected. Vitamin D therapy, monitor renal function, blood pressure, serum vitamin D levels, maintain seizure and safety precautions, and monitor for laryngospasm. See box 47.9, page 1400 for clinical manifestations. The primary manifestation is adenoma of the gland. Secondary would be chronic renal disease, congenital anomalies of the urinary tract, and common factors is hypercalcemia. This one is rare in children. Diagnostic evaluation would include blood studies to identify increased calcium and decreased phosphorus levels. Surgical removal or treat underlying cause if possible, and care management recognition of the disorder. Disorders of adrenal function. See page 1403, box 47.10. Adrenal cortex secretes three groups of steroids: your glucocorticoids, your mineral corticoids, and your sex steroids. Altered levels of these produce significant dysfunction. The adrenal medulla secretes catecholamines, epinephrine, and norepinephrine. The catecholamines secreting tumors are the primary cause of adrenal medullary hyperfunction. Acute adrenocortical insufficiency causes adrenal crisis. Etiologic factors: hemorrhage into the gland from trauma, fulminating infections, abrupt withdrawal of exogenous cortisone, failure to increase cortisone during times of stress, and diagnosis generally based on the clinical symptoms. And the clinical symptoms would be increased irritability, headache, abdominal pain, nausea, vomiting, hyperpyrexia, cyanosis, and seizures. The diagnosis, we say again, is based on clinical presentation. Therapeutic management: replace cortisol, replace body fluids, and use Solu-Cortef. Prompt recognition is essential. Then we talk about Addison's disease, page 1404, box 47.11 for your clinical manifestations. This one is rare in children, but the causes can be infections, neoplasms, autoimmune processes, or it's just idiopathic. Symptoms appear gradually over about 90% of the adrenal tissue, which is non-functional. Diagnosis, measurement of functional cortisol reserve, therapeutic management, replacement of cortisol, and aldosterone. The care management, parental guidance, and education is very important. Cushing syndrome. This is a characteristic group of manifestations caused by excessive circulating free cortisol. May be caused by excessive or prolonged steroid treatment. The condition is reversible once the steroids are discontinued, but abrupt withdrawal of steroids may precipitate acute adrenal insufficiency, so you have to find that balance. This is what a cushingoid appearance looks like. This picture's in your book if you want a closer look. But these children's face get really, really fat looking. Very round all over, and it happens really fast, so sometimes it causes stretch marks on these little children's bodies. They bruise easy, they gain a lot of weight, their wounds are hard to heal, they lose that childlike appearance. Excessive hair, moon faces is what they call that, the big round face. Red cheeks, weight gain, pendulous abdomen with red striae. Pendulous means a lot of extra gut that hangs over, like when we get older, over our, our little beer bellies or tires around the middle, whatever. And with red striae, that means red stretch marks. Poor wound healing. Ecchymosis, which is bruising. Measurement of serum cortisol levels, imaging of pituitary and treatment glands, skull films to examine the sella turica, measurement of bone density, and laboratory tests like fasting blood glucose levels, serum electrolyte levels, and a 24-hour urine collection. Therapeutic management dependent upon the cause. Surgical intervention, replacement of GH and ADH, thyroid hormone, gomatotropins, and steroids. Management, steroid administration early morning, alternate day schedule, post-operative complications. Congenital adrenal hyperplasia occurs in 1 per 12 to 15,000 births. Overproduction of adrenal androgens results in virilization of the female fetus. Varying degrees of ambiguous genitalia, where the child may have both male and female organs, whether it's external or internal or both. Salt wasting crisis frequently occurs, and diagnosis is based on congenital anomalies or abnormalities. And of course, they do a newborn screening on all children. So they're going to administer glucocorticoids, diagnose and assign the sex to the child according to the genotype, or in this day and age, they may not do that. They let the parents decide, or some of the parents may just want their child to grow up and let them decide which sex they want to be. Anything goes nowadays. So if the parent decides they want to make their child predominantly male or predominantly female, then reconstructive surgery may be required. Not all cases are diagnosed at birth. These are individuals that are not fertile. Pheochromocytoma is a rare adrenal tumor that secretes catecholamines. May occur around the adrenal medulla, along the paraganglia of the aorta, or along the thoracolumbar sympathetic chain. Tumors, often bilateral, multiple, and benign. Do not palpate these tumors. It will release the catecholamines and cause severe hypertension and tachydysrhythmias. Clinical manifestations may mimic those of other disorders, and they do a diagnostic 24-hour urine test. Surgical removal of the tumor or tumors may require bilateral adrenalectomy and lifelong glucocorticoid and mineralocorticoid therapy. Care management, identification of the condition, hypertension, and behavioral changes may be noted. Disorders of pancreatic hormone secretion, diabetes mellitus, characterized by total or partial deficiency of the hormone insulin. Most common endocrine disorder of childhood. Peak incidence is between 10 and 15 years of age. Increased risk for African Americans and Hispanic children. You can see on page, I don't have the page number there, sorry. It's table 47.1 and box 47.13. Type 1 diabetes is characterized by destruction of the beta cells, usually leading to absolute insulin deficiency. Onset typically in childhood and adolescence, but can occur at any age. Most childhood cases of diabetes mellitus are type 1. It's more prominent in white people. Now, I take offense, I don't know why, to the use of this book calling people white people, but nevertheless, I didn't write this slide, so this is what's in this book. So please don't be offended. Type 2 diabetes mellitus arises because of insulin resistance, onset usually after age 45. Native American, Hispanic, and African American children are more at risk for type 2, at increased risk for type 2. Affected people may require insulin injections. Pathophysiology: with a deficiency of insulin, the glucose is unable to enter the cell and remains in the blood, causing hyperglycemia. When serum glucose exceeds renal threshold, the glucose spills into the urine, which causes glycosuria. Cells break down the protein for conservation or conversion to glucose by the liver, which is glucogenesis. Ketoacidosis is when the glucose is unavailable for cellular metabolism and the body breaks down alternative sources of energy. Ketones are released and excess ketones are eliminated in the urine or by the lungs, so they'll have that fruity smelling breath, acetone breath, and ketonuria. Ketones in the blood are strong acids that lower the serum pH and produce ketoacidosis. Diabetic ketoacidosis is a pediatric emergency. Results from progressive deterioration with dehydration, electrolyte imbalance, acidosis, coma, and may cause death. Therapy should be instituted in an intensive care unit setting. Long-term complications of diabetes mellitus: microvascular complications, especially neuropathy and retinopathy. Macrovascular disease, or neuropathy, with poor control vascular changes as early as 2.5 to 3 years after diagnosis. With excellent control, can be delayed 20 years. Diagnostic evaluation: check for risk factors, glycosuria with or without ketonuria. And there are 4 different tests to confirm DM: an 8-hour fasting blood glucose of 126, random blood glucose of 200 or more, oral glucose tolerance test of 200 or more in a 2-hour sample, and a hemoglobin A1C of 6.5% or more. You have to take a multidisciplinary approach with insulin therapy. Dosage and methods of administration must be taught. Monitoring is done with blood glucose glycometer of some sort. Glycosylated hemoglobin and urine would be monitored. Nutrition, very important to teach these children and the parents about exercise as well. What can they do? What should they do before they exercise? Hypoglycemia. Sometimes in the morning they have hypoglycemia, so they need to eat breakfast. Illness management. Therapeutic management of diabetic ketoacidosis. Fluid and electrolyte therapy. When children are old enough to understand the concept, then they can be taught to give their own injections. Interprofessional care management, communication with team and other individuals is essential. The coach, the school nurse, the teachers. A hospital management if they go into the hospital, of course. Child and family education, and they need to wear medical identification. Please look at and read the care plan for the child with diabetes mellitus on pages 1414 through 1415. The nature of diabetes is explained also in this chapter. Meal planning, traveling, insulin, injection procedure, continued subcutaneous insulin infusion with some children who are too young or simply refuse to inject themselves. So a continuous pump can be implanted to be controlled electronically and to give the right amount of insulin. The dosage needs to change continuously during growth and development, so it's an ongoing process. Patient education. This child is being taught to stick their own finger to check for their blood glucose. Monitoring. Urine test should be monitored for glucose spilling. Signs of hyperglycemia, hypoglycemia. Their hygiene, exercise, record keeping, self-management, and child or adolescent family support is all very important in the treatment of these children. And the correct answer is B, diabetes insipidus. This concludes this chapter. Thank you.